don't have a cat.
Wait 1 second.
I'm Catherine Boughton. I'm the president of the chapter. Welcome to our April meeting. And it's tax day, and it's also the deadline for our scholarship that our chapter gives out to New York City high school senior with hearing loss.
I forgot why.
So it's a big day around here. We have, if anyone here does not know, I'm sure you all do by now, but we have open captions. You can go on the CC at the bottom of the screen and the captions will show up. If you can't get the captions, or if you have something you want to say while the presentations are going on, put it in the chat. It's also fine to put questions in the chat. If anyone needs stream text, we have, I think, David, is that in the chat, the link to that? Stream text gives you a larger font on a separate screen. And finally, I don't think anyone has asked for Spanish captions, but we do have those available as well. So, okay, so I'm just going to get right into introducing our speakers. I'm very pleased that we have Dr. George Alexiades.
Sorry, I thought this has to be really good for you listening to that.
He is currently Associate Professor of Clinical Otolaryngology at NYU Long Island School of Medicine / NYU Langone, Long Island. Did I get all that? Yeah. He is Director of Otology, Neurotology, and Skull-Based Surgery, which in more common terms means that he does cochlear implant surgery. He previously served as the program director at the New York Eye and Ear Infirmary and as director of the Cochlear Implant Center at Weill Cornell Medicine. He's performed hundreds of cochlear implantations over his career and has numerous peer-reviewed publications and has presented at regional, national, and international meetings in this field of otology and neurology, and we're very pleased to have him. Before I introduce Paul Lavra, I think not everybody is muted, so could you check to make sure that you're all muted? I can hear a few sort of stray sounds. Okay, Dave can also look. Paul Lavra, and he has a lot of initials after his name, MSECSLPTSSLD with some hyphens.
That's right, yeah.
Is a speech language pathologist specializing in adult and pediatric aural rehabilitation for children who are implanted before they have speech, and rehabilitation for people who are getting implants later in life. He does a couple of other things that I wasn't even sure I would be able to pronounce, so I'm going to just skip over those, but Paul, please feel free to add them in. He conducts evaluations to determine candidacy for cochlear implants or auditory brainstem implants for individuals across the lifespan. He works with users of bilateral cochlear implants, bilateral hearing aids, bimodal listening devices, sequential bilateral cochlear implants, and single-sided deafness. He works closely with implant recipients and their families, and this is through NYU, to develop comfortable rehabilitative programming to address their unique needs and goals in order to maximize cochlear implant success. And I'm really delighted that we have both of them here tonight. I'm also delighted that this rehabilitation has become pretty much standard. I know at NYU it has been for years, but other places were slower to pick it up. So Dr. Alexiades is going to start, and please hold your questions till after both have finished their presentations. Okay, thank you.
Thank you, Catherine. So I'm just going to share my screen now. Okay. Let's see. All right, everyone has that? So just want to make sure that I don't have any disclosures. But first, today we're going to be just talking about the current cochlear implant indications and all the devices that are out there at this time. So, who gets a cochlear implant? And that has been changing over the years. when they were first introduced back in, around 1980. There was a lot more stringent, the criteria for implantation. And over the years, that criteria, we've been starting to implant people with more and more residual hearing. So what was true 10 years ago is not true today. And people who were rejected in the past because their hearing was too good may actually qualify under the current guidelines. So, what do you need to get a cochlear implant? There are certain criteria that we do need. You need to have a cochlea that is open. We need to have an inner ear to be able to put the device in, and we need a nerve to connect the cochlea, to the brain. So we have to have an intact nerve that is functioning and able to send the signals that we give in the cochlea up to the brain. And the other thing that has to happen is that patients have to not perform too well with their hearing aids because we're trying to find where is that cutoff between how you do with a hearing aid versus how you do with a cochlear implant. So getting turned down for a cochlear implant is not something to necessarily be upset about. It just means that what you would potentially receive from a cochlear implant would not necessarily be better than what you're getting with your current hearing aids. We always want to make sure that when we put a cochlear in, that we are going to leave you ultimately hearing better than how you performed with your hearing aids. We don't want to just do an operation and then have you perform just about the same as you did with your hearing aids. So, but as cochlear implant technology has gotten better over the years, that's why we're expanding the criteria and implanting patients who have a lot more residual hearing, because we've seen over the years that they do better with cochlear implants than they were doing with their hearing aids. So what are some things that prevent you from getting a cochlear implant? And those are, these are some absolute contraindications, which are if the cochlea is ossified or totally scarred in. So normally the cochlea has the internal aspect of the cochlea has fluid in there, and we have to be able to. Yes.
Sorry, forgive me the interruption. Perhaps you shared the wrong screen. We see just one slide and nothing advancing.
You're not seeing my slides advance?
No, we're still on the title slide. We see the organizing PowerPoint slide with the main title slide in the center, and then a list of your slides on the left.
Right, I'm going to share again. Let's see. Do you have my current slide now?
Yeah, that looks right.
Sorry, thank you. So contraindications. So we were talking about a cochlea. You need to have an open space for us to be able to put the electrode into the cochlea. So there are situations where we can't do that. And there's a lot of scarring that can happen in the cochlea, particularly in patients who get meningitis. Shortly after meningitis, there can be a lot of scarring that happens in the cochlea that starts even as early as 6 weeks after meningitis, up to a few months afterwards, where the cochlea can scar in and we can't actually be able to insert the electrode into the cochlea. It also happens in patients with otosclerosis, but that's much rarer. But in more advanced otosclerosis, you can sometimes get bone deposits into the cochlea that prevent it. There are also situations that people are born without a cochlea. So if there is no cochlea to begin with, then a cochlear implant is not an option. The same holds true for patients who don't have cochlear nerves. So if there's no connection of the cochlea to the brain and that cochlear nerve never formed, then that would be a contraindication to the implant. And that can also happen after surgery for benign tumors on the nerves of hearing and balance. Sometimes the cochlear nerve is involved with the tumor or is sacrificed with the tumor removal, and then those patients wouldn't be able to be a candidate for a cochlear implant. Is it moving forward, my slides? Okay. So what are some relative contraindications? So these don't necessarily preclude you from getting a cochlear implant, but there are other things that we have to take into account when we're evaluating patients for cochlear implants. One is if you can't get medically cleared for surgery, if you have a lot of medical issues where you can't undergo anesthesia, or the stress of the surgery itself would potentially be problematic. There are times that we can do these under local anesthesia with so just some local anesthetic and some sedation. But again, you need to be cleared by your primary doctor. Other things that could potentially come into play are if you've had deafness for a very long time and have never worn hearing aids. There are patients out there with 20 or 30 years of hearing loss and have not been aided over that time. It's not an absolute contraindication to surgery, but it does decrease the effectiveness of a cochlear implant. So we have to take those into account with the expectation. There's some people that are not muted. Also in the same vein, having unrealistic expectations of what you're going to get with a cochlear implant. It is not going to be normal hearing. So we just need to make sure that you understand what you're going to be able to get with a cochlear implant as compared to normal hearing. Patients with chronic infections in their ears, that needs to be addressed before we put a cochlear implant in. It is a foreign body, so we don't want infection over that, because once it gets colonized with bacteria, it becomes extremely difficult to get rid of. And oftentimes that would require us to remove the cochlear implant, clear the infection, and then put a new implant in. But there are things that we can do to get that ear dry, get rid of the infection. And then once the ear is clear, then we can go back and then put in a cochlear implant. Social and environmental issues. These are whether there's enough support in the home to be able to utilize the implant. There's a lot of it, especially with children in particular, that the family is invested in getting the child all the resources that they need. And the same holds true for adults who are in certain situations at home. And if they're just sitting at home alone with no interaction with people and, maybe listens to the TV, they may not do very well with the cochlear implant. So we have to make sure that there are some support at home and at the workplace to make sure that they do well. And there's also the commitment, to the rehab time after the implant. It is a lot of time that you have to put into to learn how to use a cochlear implant. And if you don't have the commitment to do that, then you're going to have more limited benefit with it. And so you may not do as well. So what are the current indications for cochlear implants? So right now, there is some variability between adults and children because we are more stringent in children. And that is because in children, it's much harder to do word understanding and sentence understanding in children. So in very young children who haven't really developed speech yet, we have to be a little bit more stringent as to the degree of hearing loss that they have when we make the decision about a cochlear implant. But currently for adults, we are talking about patients who have a moderate, potentially up to a moderate hearing loss in the low frequencies. And then it really progresses down to a profound hearing loss in the mid to high frequencies. For children 2 years and above, it's a severe to profound hearing loss. And in children under 1 year or under, then we're talking about a profound hearing loss. And that is just really, as you get lower on this graph, your hearing is worse. And so we just want to make sure that we're selecting the correct patients for who would qualify for the implant. And in an adult situation, we're talking about in the ear to be implanted, we're looking at sentence recognition of less than or equal to 50%, and in the opposite ear, less than 60%. And so this is a little bit different than word understanding you get on a traditional hearing test. There we're looking at words. Here we are looking at sentences. And so there is, it's not a perfect translation, with respect to the hearing test that you normally get every year when you're testing your hearing and when you're getting evaluated for a cochlear implant candidacy. So words, we generally say, when patients on a hearing test are in the 50 to 60% range, we can start thinking about, getting an evaluation if they're struggling. Then there are, patients that we're talking about what's called a hybrid or electroacoustic stimulation. So these is a newer category of patients that we're implanting compared to the traditional patients. And these are patients who have very good low frequency hearing, but very poor mid to high frequencies. So we use the natural hearing or a hearing aid for the low frequencies, so you get a more natural sound. And the cochlear implant gives the mid and high frequencies that the hearing aids can't really reproduce well enough in those patients. And your brain learns to fuse all those signals together to be able to hear better. And so these are the indications for the Cochlear Corporation for their hybrid implant. And so now we're talking about patients who have normal hearing in an adult is 25 and above. And so we're talking about patients who have normal to a moderate hearing loss in the lows, and then it starts to really descend in the mid to high frequencies. So again, the hearing aid supplies the low frequencies or just your natural hearing, and then the mid and high is with the cochlear implant. And for the ear to be implanted, their word understanding has to be in the 10 to 60% range. And for the opposite ear, it has to be less than 80%. This is for the other company that also does EAS, which is MED-EL. And again, it's a very similar category of hearing loss, and they just have slightly different indications, but it's all very similar. And we want to make sure that in this category of patients that their hearing loss is not progressive, because if your hearing loss is changing, you're going to go from a hearing from this category, it's going to continue to decrease, and we don't want to necessarily use certain electrodes, in that situation, because your hearing is going to continue to decrease, and we want to have a longer electrode that will supply everything that's necessary should the hearing continue to drop. This is another newer category of hearing loss, and this is single-sided deafness. So traditionally, everyone said if you had one good ear, you're good, and you don't need a second ear, and insurance companies did not want to pay for this for years and years and years. But finally, the FDA has approved cochlear implants for single-sided deafness. The interesting thing is one arm of the government approves it and another arm hasn't yet. So CMS, which is the governing body for Medicare, has not made a determination on whether they will pay for this device. So Medicare patients still are exempted from this because Medicare will not cover single-sided deafness indications. And these are people who have unilateral hearing loss. So they have a severe to profound hearing loss in one ear, and then the other ear is normal or near normal. These are for patients 5 years and older. And like I said, the ear implanted would have a severe to profound hearing loss, and the opposite ear is a normal to near normal hearing. And there's no significant benefit with a hearing aid in the ear to be implanted. So now we're just going to go over the 3 corporations that have devices that are approved for use in the United States. And those companies are Advanced Bionics, Cochlear Corporation, and MED-EL. Advanced Bionics, their current internal device is called the Hi-Res Ultra 3D, and they have 2 different electrode arrays, the Mid-Scala and the Slim J. This is what their cochlear implant looks like, and all 3 manufacturers have very similar looking devices now, as they've all become more and more similar over the years. These devices, the magnet used to not be MRI compatible in all the older implants, but now all the current devices out there are able to be compatible with MRIs up to 3 Teslas, which is just the strength of a magnet, and they can do that with the magnet in place. But in situations, you still get a lot of scatter and signal voids from the magnet. So if you really need to image a certain portion of the brain near the device, then we can remove the magnet, which will really decrease the scatter that happens on the MRI. And these are their two electrodes. They have a straight electrode and a pre-coiled electrode. And it's not something that you have to need to be too concerned about, but this is something that your surgeon will make a determination about once you choose a company. Cochlear Corporation has their current device is the nucleus profile device, and they have an assortment of arrays as well. This is what their device looks like. And again, you have this magnet that is MRI conditional. And what they mean by that is external processor needs to be removed. And there are certain things that the radiology place needs to do to make sure that there aren't any issues while you're in the magnet. And these are all their different electrodes with just their different lengths. And again, your surgeon's going to make the determination about which electrode is most appropriate, for your cochlea. And Medel, their current internal device is the Synchrony 2, and they have it with and without pins, which just determines, depending on how you seat the device in the skull. And they have a multitude of electrodes that are different lengths. And this is their current device. And as I said, they all look very similar. Also MRI conditional to a 3 Tesla magnet. And like I said, there's these little pins here for people who don't like to seat the device into the skull, where we put a recess and what we say is we make a well for the device that prevents it from moving in the skull. About 50% of surgeons don't do wells. So they just, in this device, you can make 2 little tiny holes in the skull, and then the pin goes into it and it prevents it from moving. So then it doesn't migrate over time. And then these are all their electrode lengths. And a lot of it has to do with the size of the cochlea, because they tend to have longer electrodes that can go into bigger cochleas. And then now we're just going to get to, we're just going to show a little cochlear implant surgery. It's a short video. I tried to cut any gore out of it, but if you're very squeamish, you may not want to watch. But so it'll just be, and I'll help narrate just what we're doing as we go through the surgery. And let me just click this. So we make a little incision behind the ear. It tends to be, just a little bit behind the ear and curves a little bit backwards and upwards. And if anyone has watched The Pit, it's very similar to that. But and so after we cut through the skin, we then mark the area of where we're going to put the device in. This is a little dummy device to help us determine where we're going to seat the device in the skull. And then we drill that bone away. And you can see this is an older device that was a little bit thicker. So I used to make my pocket a little bit deeper. And that just allows the device to have a lower profile, so you don't feel it as much. And that device is not going anywhere. And then this is where the electrodes are coming out of the device. And now we start to open up the mastoid, which is the bone behind the ear, to allow us to be able to get to the cochlea and make our hole into the cochlea. This is where the lead wire from the device is going to go into the cochlea. So we have to just recess that into bone. We make an opening. The facial nerve is right here, so that we have to stay away from. And we want to just expose the cochlea, which is right here. And we're going to make a hole where I'm pointing to. We're going to make a hole into the cochlea right there to allow us to put the electrode in. And here we got to the inside lining of the cochlea itself. We're going to put the device into that pocket, retie it down so it's not going to go anywhere. And so these are the little sutures. We just tie that up. Very quick, beautiful. And so that's not going to move anywhere. And then now we opened up that hole into the cochlea, and now we insert the electrode very slowly. And this is an older device that had a stylet. It's a pre-curved electrode. And we just slowly insert that into the cochlea. And then we pull that stylet out. And there's these little stiffening rings that we want right at the opening to the cochlea. We pack that little opening with some tissue. We coil those little lead wires into the mastoid, and then we just close everything up we have this little flap that we cover the device in case the skin breaks down, and then we close the skin up, and then everything is all healed up. And then about 3 weeks after that is when we turn the device on. So you will not hear immediately after surgery. And if you have some residual hearing, we do try to preserve that. But in the first few weeks after surgery, that's going to be a little bit worse because you're going to have a lot of blood and fluid in the ear. And then we see what it's like when we turn it on in 3 weeks. And that is it. Sorry, Catherine, you're muted.
Sorry. No, I'm not muted. I was just saying thank you. The video was absolutely amazing. And I'm a big fan of the pit, so I could have endured some more blood. So now Paul Lavra is going to talk. And for those of you who weren't here at the very beginning, we're asking if you hold your questions until both presentations have been made. Thank you, Dr. Alexiades.
Can everybody hear me okay? Okay. And then I'm going to give a try at sharing my screen, and let me make sure that this works as well. So screen one. Share presentation. Okay. Everybody can see that? Is that okay? All right. And then I'm just going to do a practice advance. Can you see that? It's a different slide? Okay. I want to first thank Tony and Dr. Alexiades for bringing me in here to talk a little bit about what I do at the Cochlear Implant Center. So my name is Paul Lavra. I'm one of 2 speech pathologists that work here alongside of all of the audiologists into working alongside of those with cochlear implants. My talk today will be specific to those cochlear implant recipients or those thinking about getting a cochlear implant, about what happens after they meet with Dr. Alexiades. So when I meet with an individual, it is before surgery happens, and they have many appointments before then. So they meet with the audiologist to have their hearing tested. They meet with the director of our department, and he walks them through the different devices that are available to them. And then they meet with me. And the first question that I ask somebody, I say, did anybody explain who I am or why you're meeting with me? And overwhelmingly, most people say no. I know that you're a speech therapist, but they tell me my speech is just fine. Or they get worried and say, is this implant going to change the way that I sound when I talk? And what I tell them, I say, no, it's not about your speech, believe it or not. Or sometimes it is if you want to work on precision of sound production. But my role is to really help you more easily understand my speech and that of your partner, your spouse, your family, your friends. So when you meet with me after surgery, it is in an effort to really maximize what the cochlear implant is able to do for you. And that, our work together, is called aural rehabilitation. And this is just explaining that we're able to really make sense of listening in a new way. So if any of you are listening with hearing aids, your hearing aids are simply making things louder. And that can only take you so far sometimes, where you're not really accessing my voice or the sounds around you as well as you could be. This is making things louder with hearing aids. A cochlear implant, as Dr. Alexiades was explaining, is sort of stimulating inside and introducing sound that's unfamiliar. So in rehab, we'll work on improving your ability to understand spoken voice first, allowing and making it such that you feel a little more confident when you're interacting with people. Many of you probably experience difficulty in noise, and the implant and the accessories that come with it can make that sometimes easier for you than it would be with just a hearing aid or hearing aids. If you're listening with one really good ear and one not so good ear, it's going to be a lot harder to localize sound too. And a cochlear implant may give you more information such that that's easier. So that's also something we would practice. And I think the biggest picture is just allowing you to participate. Again, almost everybody I meet expresses, I'm not able to socialize as much as I would like or that I had used to. I'm nodding when people talk to me, even though I don't really know what's being said. I laugh when other people laugh, even though I don't really know the joke. And people start to become reclusive because of their hearing loss. And I think the biggest goal of the implant is to squash that and allow you to exist and participate in a way that you really want to. So who's eligible? I know Dr. Alexiades talked a bit about this, so maybe I'll cruise down. But for rehab, I don't only work with individuals with cochlear implants. I work with some individuals who are listening with bilateral hearing aids, maybe with one cochlear implant and one hearing aid, sometimes one hearing aid and nothing, or sometimes nothing altogether. So anybody with a hearing loss can benefit from rehab services. If you're just implanted and you're getting started with your new implant, we can work together. If you've been implanted for a really long time, there's probably a good shot that there's some new tools or even some sort of philosophies on mapping that might be useful to you. And then we put those to use in rehab. Anybody who's noticing that things are changing. So your hearing after an implant and after you're established with it shouldn't deteriorate. But if you're experiencing some concerns, we can take a closer look and practice why that might be happening. Like I mentioned, I've been listening with an implant or I've been listening with a hearing aid, and it's still not really giving me the benefit that I'm hoping for. We can sit and practice that, right? There's accessories that may be helpful. There are self-advocacy strategies that may be helpful that we can sort of work through. Many of the individuals that I work with begin to experience cognition concerns of memory, and we can also work on those executive functions and sort of organizing one's thoughts in relation to hearing loss. And then also, I mentioned it a bit earlier before we started that I'm really happy to sit down with family, friends, loved ones, colleagues, and explain to them how they can more easily support their loved one with a hearing aid, with a cochlear implant, or with both. So sort of this big messy slide, a simple way of putting it is really anybody with a hearing loss can, I believe, in what research is showing, can benefit from rehab services, no matter how long ago you were implanted. I want to talk a bit about access to sound in relation to speech and what we would do together. And to do that, I want to show sort of a map of hearing, human hearing. And you may have seen something similar to this in your time with your audiologist, where, here we go, let's see. Can you see my little laser on here? Okay. I want you to think of this like a piano, where it's going from low pitches, low sounds over here on the left, and then all the way up to the high sounds, the high pitches over here. So like a piano, low to high, bum, 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 bum. And then everything at the bottom down here is really loud. And as you go up, sounds get softer, okay? So we have low to high, and then loud to soft. Now this little banana, this little eggplant guy, that's your voice. That's my voice. You'll notice it goes pretty well from low to high, but it's more soft than a lot of the things that are around you. There's on this chart, your hearing will be mapped out. Okay, so when you meet with your audiologist, they're going to show where your hearing lies on the chart. And this is a gentleman who was implanted just over about 1.5 years ago. That blue line represents his hearing without a hearing aid in his ear, right, in his left ear. So think of this blue line like water, okay? So anything underwater, he could probably hear without a hearing aid, right? But you'll notice that's not speech. That's not human voice, and that really matters. He's getting really, really loud sounds, and that's about it. So he was fit with a hearing aid, which then brought his hearing to here. So he has now more access to sounds. Maybe he can hear the phone now better than he could, or maybe he could hear some lower speech sounds, but he's still really missing out on a lot. And then he was implanted, and a year afterwards, his hearing was tested again. And in his implanted ear, his new line is way up here, and it includes a lot of spoken voice. So going from no detection, no awareness of spoken voice to a little bit more with his hearing aid to a lot more with a cochlear implant. So I'll talk about it in a bit. Now he can hear the sound, but the question is what does he do with it? And what does it sound like? So these are just his scores. Pre-implant, I meet with you, somebody thinking about an implant, and your audiologist does all these tests with single words. Sometimes they introduce noise, and oftentimes sentences. When he was first tested before the implant, in his left ear, he got 0% of the words correct and just 1% of the sentences. So he was implanted, and 3 months later, he comes back. His audiologist evaluated him, and you'll notice now with words, he's getting 76% of these words correct with his implant on its own, which is remarkable for 3 months, going from 0. And then his sentences went from 1% with that ear to 95, which is an incredible accomplishment in 3 months. And then finally, at the 1 year mark, you see his scores sort of top out here around 88% and 96% in sentences. And at the bottom, they start to introduce noise and see how he does with noise with his cochlear implant. So his progress was remarkable over the span of that 1 year, going from no hearing, no comprehension to almost entirely perfect. One thing that I really think is important prior to surgery, and what I think the crew here does a really good job with, is setting expectations, right? A lot of people are very comfortable with their hearing aid. They hear about a cochlear implant and they think, this is the ticket, right? It is not like a pair of glasses, which is commonly a misconception. They think they're going to get the implant and things are just going to click, that they're going to understand everything and that it's going to sound good right away. And that's really not the case. It's not like glasses. This, like Dr. Alexiades said, it takes time, it takes commitment, it takes a lot of effort to go from that 0% to an improved score. And there is really a hierarchy that we follow in rehab. The day that your implant is turned on, you may understand things, but what we're really looking for first is, are you hearing anything? Are you detecting sound? So I'll walk you through the hierarchy of what to expect after receiving a cochlear implant. So Dr. Alexiades said, I'm going to do the surgery, and then you have 3 weeks to veg out. You let the incision heal. You come back, and your audiologist is going to turn your implant on. And that'll be the first time that you really experience sound since surgery, right? So the very, very first goal is detection of sound. Are you hearing that sound is happening at all, right? Or are you acknowledging that sound is not happening? So many people will come in and say, oh my gosh, everything's so loud. It sounds like fuzz, it's echoey, it's mechanical. I can't really make sense of anything. I'm definitely hearing it, but I don't really know what it is. And we say, great, you're hearing it. This is a really good place to start. Then we move up to discrimination. And this is really your acknowledgement that sounds are different from one another. So yes, you're hearing it, and we know that you're hearing some of the highs and you're hearing some of the lows, but can you acknowledge that they're different, that the phone is ringing and that somebody's banging on the door and you say, whoa, those two sounds are different from each other. Or I'm speaking, Dr. Alexiades is speaking, and you say, wow, those are two people talking and they're different from one another. I don't know who's who. I don't know what the heck they're saying, but I know that those voices are different. And then we graduate to identification. That's you saying, oh, yeah, that's Dr. Alexiades' voice. I still don't really know what he's saying, but I know it's him based on, the personality, the rhythm. I know that's my phone ringing because of the ringtone. I recognize that pattern. And then if I were to say this is everybody's goal, I think I could really speak for that often. It's comprehension, understanding what somebody is saying with your cochlear implant is often the goal. Now, there are instances where somebody's coming and they say, look, I know I've had this strange surgery and I know my outcomes don't look great, but I have this ridiculous ringing in my head. And if I can get rid of the ringing through surgery, even though I won't understand things, this is worth it to me. And some people will say, if I can't comprehend what people are saying, it's not worth it. So we really work very carefully on setting expectations based on your specific body. And the surgeon is very careful to look at your imaging. Dr. Alexiades mentioned the electrode arrays. Everything is customized to you, right? So we want to make sure that at first, things are going to sound a little strange. They'll sound metallic or echoey or robotic or high-pitched, right? And that's common, but we want you to know that, right? And be prepared for that. So this is the hierarchy we march through. It's turned on. I'm not worried about right away, do you understand me? It's, do you hear me at all? And then we build on top of that. There we are. Okay. When I go through the hierarchy, many people say, well, how long does this take, right? It's something that I'm getting the surgery because I need to be a participant. I want to be in society again. And unfortunately, there's not a really clear answer. And this is a tough question to answer. It really depends and it varies how long this is going to take one to get there. So I mentioned before, it may be that you never get there, right? But overwhelmingly, one would, right? So it depends on factors like this. Like Dr. Alexiades mentioned, the longer you go with a hearing loss that's unaided, it's going to be a lot harder. It's not to say you can't get there, but it's a steeper hill, If you've had a hearing loss for a very long time and you've worn a hearing aid, that's great. You're keeping that part of your brain active. And your outcomes, we believe and we experience, are often better when people have access to sound. Dr. Alexiades also mentioned that, there may be some contraindications based on your anatomy or why you have a hearing loss, if there's tumors or a nerve that's not really strong. He also, too, mentioned the commitment part. Believe it or not, a lot of people will get the surgery and then not wear the device as much as we encourage them to. And that's really suggested that they wear it all waking hours, which sometimes it's for people who are wearing it 18 hours a day, which is certainly much longer than I'm awake. Wear time is really important. Concerns of outcomes based on cognitive abilities or even just access to care. It is a little harder when somebody lives by themselves. Or doesn't have a family to support them, or doesn't have constant sort of barragement of sound. But at the bottom, I think this is important to highlight. People often say to me, I'm a little too old to be getting this, aren't I? And overwhelmingly, the answer is no, right? I think age, of course, does matter, but it's less of a factor than you might think. And there's a gentleman here who is now 103 years old who is still regularly programmed. And I see him every once in a while to check in to make sure things are going well. And now as young, there was just a 5-month-old baby that was sitting 2 feet from me today, who's also in that same boat. So age is much less of a factor. I don't know if he's here or where he might be. I see someone's raising their hand. Oh, okay. I can view these. I don't know. Is this to answer a question? Does somebody want to ask a question? Or I don't have access to the chat right now because I'm sharing my screen. Is anybody seeing anything in the chat? Or maybe we could wait till the very end?
There is one question in the chat, but we can wait till the
Okay, all righty. Thanks,
video.
Catherine. Okay. Age is much less of a factor. Dr. Shapiro I know he counsels patients and they say, oh, I'm 86 years old. What do you think? And his suggestion is, look, if you get another 6 months of your life, which is great, and you can hear better in those 6 months, then why wouldn't you do it? So I think that age really shouldn't play that big of a role from my rehab perspective. Okay, let's see if I can skip ahead here. Okay, these are just some of the reasons. I'm too old. I'm not tech savvy. I can't handle general anesthesia. That surgery looked pretty intense there. And people worry about the effects of the anesthesia. I'm not deaf enough. Dr. Alexiades also said, if you maybe were evaluated 10 years ago and you weren't a candidate, that might not be the case now. Inclusion criteria is changing. I don't want to
Can
look
I
like a
interrupt?
robot.
I'm
Go for
sorry,
it.
can I interrupt? The captioning is not working. The captioning, the last thing I'm seeing is, do
Actually,
you hear me? And then
captioning
we do
is
it on top
working.
of that. That's the last thing the captioning showed. I'm sorry to interrupt, but
It's no problem. Yeah.
The captioning is working. It must be something in your Wi-Fi. I had the same problem at last meeting.
I think too,
Harold,
and I hope that these will be sent out if there's any questions. And I'm, of course, happy to review anything or go over it again if there's some sort of disconnect.
Harold, as a backup, Harold, if you hear me, you can use the stream text link in the chat, and that will give you the captions if you can't get them through Zoom. I've just placed that link again, but that will give you the captions as well.
Thanks, everybody. So these are some of the reasons people suggest that they're maybe not interested in rehab or a cochlear implant. Many people express this frustration with the vanity part of it. I don't want to really look like that. My hearing aid is real sleek. It's real sexy, but the implant is big and bulky. And what overwhelmingly what people tell me afterwards is they say, boy, this could have a balloon on it and I wouldn't really care because it's really given me, my life back in a big way. And then, I don't want to be a burden. This is going to take me getting to the hospital and my family's going to have to take off and all this. What I understand from families that tell me is this makes their life a lot easier. It makes their life a lot more comfortable for their family and those types of interactions. Okay. Okay, so we talked a bit about those. Hearing, okay. I posed the question of how long does it take to get to comprehension? So typically we'd say hearing loss later in life with a hearing aid. We expect to know how things have gone by about 3 months, and then beyond is when we shake out the listening and noise. We work on locating sound, music appreciation. If you were born deaf, somehow were successfully hearing or aided by hearing for a while, you may only get discrimination identification right away, but comprehension could take longer, right? Or if you were born with a hearing loss, never aided, and didn't have access to good, juicy sound for a while, maybe the benefits of a cochlear implant will be less apparent. Maybe you'll get awareness of sound, which could still be incredibly helpful in terms of a safety measure or mechanism, but you might not get comprehension the longer you've gone without good aiding. So again, it's not a quick fix. This is something that takes time. It takes practice. It takes an effort from you and your family. The sound quality at first is going to be a little bit of a tough pill to swallow. It might sound echoey or metallic or robotic, right? But as your brain experiences sound, as you adjust to it, things will sound fuller and warmer and complement maybe your other ear better. It very likely won't recreate the sound as you remember it, or it may not capture the sound as well as it does in the other ear. But many, many people say, yeah, I understand you. It sounds a little different, but it's so much better than what it was before. And to expect that, there's going to be good hearing days and not so good hearing days. And you guys, I'm guessing, know that pretty well. And that's true with the cochlear implant as well. Okay, here's a very brief review of what the first year of appointments in rehab would look like, right? So Dr. Alexiades mentioned this is a commitment. You got to be here. You have to stick it out, right? You get the surgery. After surgery, you have 3 weeks to let that incision heal up. You come back. Your audiologist is going to turn your implant on. And I encourage the recipient to think of this like getting into a cold body of water, right? You're going to put your toe in, and your audiologist is very carefully and very gently going to introduce you to sound, right? It's different than your hearing aid. And then they'll send you home and say, be free and listen for the next week with your implant, and then come back. And then there's regular appointments over the first year where you'll meet with your audiologist, and then you'll meet with me right afterwards, and we'll do some of our exercises. And as you continue to meet, you're getting kind of pushed further into the pool, right? And you're getting used to it and you're acclimating. Many people at the 1 week appointment express to me, what did I do? This is not what I expected. Things don't sound so good. And it's easy for me to say, because I don't have an implant, but to say, okay, hang in there, continue to wear it. Things will continue to improve with more experience. And they come back at that 6 weeks and say, woo, I was pretty worked up there, but things are sounding a lot better. And that's only even more true the longer you continue to come back. Okay. So that's about the first year at a bare minimum. If myself or you or your family or your audiologist feels that there's still, some room for improvement, then you and I continue to meet for rehab and continue to meet for practice. And I'll show you some examples of what that practice might look like. And a lot of these really do apply, not just to implant recipients, but those with a hearing loss, right? Listening with hearing aids or not, these can help your listening skills. Not just listening, but your comprehension, your understanding skills. Okay, so the implant is turned on, you're hearing sound, but you're not really understanding it right away. What I do is I'll give you text, right? I'll say, look at this. I'm going to read it to you. Okay. So there's a big, long sentence, and you'll say, wow, I'm understanding how what I'm hearing is supposed to be that sentence, right? And you say, okay, good. And they'll say, well, it's cheating because I'm looking at it. And I say, no, that's the point. And don't forget, you're listening in a totally new way, right? So I say, give yourself some credit here that you're understanding how that sentence in text could relate to what I'm saying out loud. And then I'll compare it to a really short sentence. And I'll read both. And I'll say, please listen to both of these as I read them to you, okay? And then what I do is I'll say, I'm going to cover up. And I'm going to read one of these, and your job is to tell me which one you understood. So I cover up, and I read one, and people say, oh, but that's easy because I know it's really long. And I say, well, that's great. That shows that you're getting that information. You know that it's long. I didn't tell you it was going to be long. You were able to do that with only your cochlear implant, right? So we're maximally contrasting things. There's a really long sentence with text right in front of you. And there's a really short one, and you know the difference. And that's great. That's a good start. So as you move along, the sentences get to be more similar, right? So any word that is the same color maybe could be easily confused because of the sounds, right? So these sentences are the same length. So you can't use that excuse anymore. I heard it because it was long. Okay, now these are the same length, but they're different words. They're different sounds. Sometimes they're different vowels. So I read all three of them and I say, just listen, take it in. This is what that sounds like. And I can point, Paul dazzles the room with clever jokes and dashing looks, right? Great. And you say, okay, I'm getting bits and pieces of it. And I say, yeah, wonderful. Which ones? And we want to know, like, which parts are coming through and which aren't. After I give you the primer of just listening to it 100 times if you want, then I cover up again. And I say, all right, prove it. I'm going to read one of these. Let me know which one you think you heard. And it's a lot harder than you might think to tell the difference, because before you were using an anchor and saying, well, I heard this word, so I knew it was that sentence. You don't really have that option here. It's so much more similar. And then I start to, again, remove context. I'm going to read a sentence. You got to fill in the blanks here. So I cover up and they say, okay, I'm hearing those anchor points. I'm having something for something. And they say, Paul, I can't get it. I don't know. I know it has maybe 2 syllables, or I know that it has 1 syllable, but I don't know. So then I give them context. I say, these are your options. I'm not going to tell you which they are. I'm just going to make a sentence. I'm having curry for breakfast, right? And they say, oh, well, I only know it because it's in front of me. I say, fine, right? That's okay still. It graduates then to words on their own, void of context of a sentence that are really, really similar. TH, S, and F are really hard to tell apart. On that map I showed you, they're close together. They sound very similar. They don't look similar, so if you saw my mouth, you would be more easily able to tell them apart. But I'm not worried about how well you're able to read my lips, so I cover up, right? And your job is to say, can I tell the difference with only my cochlear implant, the difference between thin, sin, and fin? And it's ridiculously hard, right? So this is something that would be further down the road when you're listening with an implant. There are tons and tons and tons of online resources that you can do from your computer, that you can do on your phone, that you can do with a family member that can really improve your ability to use context or not. So this is an example of a website from Advanced Bionics where this lovely woman, Joy, will say something, right? And it's your job to figure out what, right? So you might say, oh, well, I'm looking at the words and it's not that hard. So we can either hide the words or we can hide the video so you're not seeing her mouth, right? So I think she said, oh, the old scarf is $135. And it tells me, no, you're not right. You're close, but not quite. So then I listen to it again. And if it's not good with her voice, I can switch to other speakers on this website. So there's 6 people you can listen to. And then it says, okay, it's actually the green scarf is $5. It then graduates towards conversation. So your ability to listen to 2 different people talk and then maybe answer some questions about it, right? If that's still too easy, you could introduce background noise. And this is sort of simulating what it might be like to be at a party where you're trying to follow a conversation and there's a lot of chaos around you and it's not that simple, right? The nice thing about these tools is you can listen over and over and over and over and over again without the sort of fear and frustration of having to have somebody repeat themselves, right? These are good pals because they could say things as many times as you want. So I can't guarantee what the outcomes will be, but I can guarantee there are tons of resources for us to use to really maximize the benefit of your cochlear implant or hearing aids. Right, so my job also is to just help you with these things. These are your cochlear implants, one that you may have. And then whether you have an implant or not, you might recognize a lot of these and say, oh, it comes with all these things, but I don't know really how to use them. That's also something that I'm happy to do, is to sit down with you and show you, look, yeah, these aren't so complicated as they maybe appear. Because they either have a lot of buttons or they have none at all, and either one of those can feel pretty overwhelming. So I constantly sit down with people and show them, look, you can do this, and I'll show you how, and then you show me how, and then go home, right? And then I pulled up these 2. If anybody in the group is thinking about an implant and still has those feelings of it looks not good, right? I find them to be really quite discreet sometimes. You can match them to your hair color. You can match them to your skin color. That's one that happens to go off the ear. There are some that go over the ear as well, and you see that they can really quite easily blend in. Okay, how to meet with me or somebody like me? I really encourage you to check in with your audiologist or your hearing healthcare professional. If you're not sure of what to say to them, just mention, hey, I want to think about aural rehab. I want to talk about listening practice or speech therapy. Do you know anything about that stuff? And if they do, hopefully they'll point you in that direction. Say, yeah, we can offer you that. If not, you can reach out to me, and I know we are totally happy to help. I see individuals, of course, mostly who were implanted at NYU, but many come here too if their facility does not offer services, or if they're way out in the middle of nowhere. We're also all able to see you over the computer, which, believe it or not, can be really, really well done with a cochlear implant. Sometimes you can just connect directly to Bluetooth, and that's a great way of practicing with me. Okay, this is probably the biggest question. Yeah, rehab sounds great, but who's going to pay for all of this stuff? It sounds expensive. Here's the answer you're probably expecting. It kind of depends, right? So many private insurances pay. Sometimes there's a copay, sometimes there's not. Medicare and Medicaid coverage varies, right? This is not a satisfying answer, but this is the answer, right? So what I really encourage you to do is to check with your audiologists, and I am happy to provide the codes that they need to type in to see if it'll be covered or not. Less likely, but there are community resources that could be helpful. And then if you got the big bucks, you can pay out of pocket. And sometimes that's the only option as well. Okay, so just to sort of recap, rehab can be really, really wonderfully helpful to many different types of people. If you're newly implanted, if you were implanted long ago, if you're listening with hearing aids, or you don't have aiding at all, if your family or friends want some support, it's something that I can offer. The other speech pathologist here is happy to offer. Or there's centers around New York that can help you, or wherever you live, which I imagine is maybe New York. Through rehab, you can expect improvements in your comprehension in speech, listening and background noise, locating the direction of sound. Music appreciation is one we didn't really talk about. That comes further down the road. A lot of people say, yeah, it's good. I understand people, but music stinks, and I can't really appreciate it like I used to. And unfortunately, these aren't really designed for music. That's often maybe the little cherry on top. But there are things that I can do in here. There's things certainly that Dr. Landsberger is thinking about with music that might be able to make you more easily appreciate music. Feeling a little more independent with your hardware. I'm happy to help with lip reading and speech reading. You're probably already a lot better than you think, but sometimes people want to improve that. And then accents, right? This is a toughie. A lot of people say, I'm on the phone, people have accents. I'm in a meeting, people have accents, and it's so much harder for me. And those are things we can practice too. That's me. If there are any questions about anything at all that we don't address today, or something pops up later, please, please, please let me know. This is my email, wherever it is on the screen. And that's my direct number. If I don't pick up, please leave a message. It is just because I'm with somebody that I didn't pick up, but I'm happy to return your call or email about anything that I've talked about so far. Okay. And that's rehab. I want to say one thing. I just feel really fortunate to be able to do this, because every single day I'm witnessing what an accomplishment for humanity these implants are. And to watch that video that Dr. Alexiades showed, I'm beaming ear to ear, because it's an incredible piece of equipment. So I'm really thrilled to be a part of it, and I'm super happy to help if I can.
Thank you. Okay, you took your screen down. If for anyone who doesn't know, the way to raise your hand electronically is to go to React at the bottom of your screen and click on the heart, and the very thing right above that says raise hand. So just click on that, and then I'll know you have your hand raised, and I'll call on you in order. So I have lost the top of the screen. John Taylor, I think you have your hand raised, right?
Yes.
Okay.
So thank you for these presentations. They were terrific. And I do have a question, but before I get to the question, I just want to say I was implanted 4 years ago by Dr. Alexiades, and I'm doing much, much better. My speech comprehension is much better. I think the rehab that I did at the CHC was very helpful, and music sounds much, much better than it did before. But my question actually has to do, and it's for both of you, has to do with the speech banana that you showed. the before and after curves. The before curve started basically close to 0 hertz. The after curve, if I saw it correctly, started around 250 hertz, which is kind of middle C on a piano. So can you talk about the range that the electrodes can provide?
Paul, do you want to answer that, or do you want me to? So, yeah, you go ahead, Paul, if you're.
I'm going to see if I can share my screen again on that, what you're talking about there. Where are we? Here we go. Link. Share. Share. Here we go. Okay. Can you see that? Whoop, wrong one here. Let me, there we go.
Yeah,
Something
so the yellow line, and I hope it's yellow because my color vision isn't very good, starts at 250 hertz. Whereas the before started at 125.
So I would have to pull up the gentleman's testing. I map these based off of his audiogram. So I'm not the one doing the audiogram, so I'm not sure the specific protocol in which preoperative or postoperative testing is done. And I imagine that it would vary from person to person based on how they're doing. The electrode array, and correct me if I'm wrong, Dr. Alexiades, should really give you access to the entire meat of human speech. The devices are designed for that purpose first, where I tend to give the analogy like a window, right? Think of human voice like a window. A cochlear implant will have it fit perfectly through there, right? And there's not a lot of margin for extra information like music, where there's bass and percussion and instruments. So you're trying to fit a lot of information through that same window for speech. But the implant itself should be designed to pick, or to my understanding, is designed to get the entirety of spoken voice. And maybe
I'm
Dr.
asking because
Alexiades.
my impression is I do hear bass voices worse than higher voices.
Right.
Bass voices are, below 250 hertz.
Yeah.
Can I jump in?
Yeah, step in, David.
Sorry. So this is a funny little artifact here that you're seeing. So the lowest frequency, so cochlear implants represent a particular frequency range based on electrode position is one set of frequency ranges, and by time coding for lower frequencies. So a weird artifact is if you play a pure tone, which is what's used for an audiogram, most devices cannot represent much below 250 hertz. However, if you have something with a harmonic structure, which is just about every sound that you will experience in the real natural world, that harmonic structure will provide a temporal code through the cochlear implant, which is how you hear it. So if you play a note or you hear a person's voice resonating at 120 hertz, that 120 hertz is delivered beautifully through the cochlear implant. There's a weird side effect is if you play 100 hertz or 125 hertz pure tone, which you never hear in the natural world unless you're listening to a tuning fork. That is not represented well, which makes literally measuring an audiogram at that frequency challenging and not particularly accurate, even if that frequency is represented very well in the real world through an implant.
Yeah, and preoperatively, because that specific patient had some significant low frequency hearing, that's why they tested down at 125. Traditionally, we don't usually test below 250 on a traditional audiogram. So because speech is not really represented in those lower frequencies. So that's why it was only on the preoperative audiogram that they tested it. But and we would follow it if we were going to looking at hearing preservation techniques and see if we preserve the hearing postoperatively, then we may have tested down to 125, but not with the cochlear implant, just natural hearing.
Thank you. I'm going to call on the people with their hands raised, and there are also questions in the chat that I will ask once we get through this the hands raised. So Eljen, you're up next.
Hi, thank you, Dr. Alexiades and Paul. Thank you for a very wonderful and helpful presentation. I have a question, which is a little bit outside. It might be a little bit outside the scope of the presentation, so whatever you can answer would be great. I have a profound hearing loss. Wear hearing aids in both ears, but one of my consequences is I have ongoing tinnitus or tinnitus, whatever is the right pronunciation. So my question is this, do you have any experience or knowledge or whatever with respect to whether getting a cochlear implant would have any effect whatsoever on the tinnitus or tinnitus? Thank you.
Yes, so Al, cochlear implants are actually very good at suppressing tinnitus, and you can say it either way. It is perfectly acceptable, tinnitus or tinnitus. They are actually very good in suppressing tinnitus while you're wearing the implant. A lot of times you will still have that tinnitus as soon as you take the processor off, when you take it off at night, you may still have that tinnitus there when you're going to sleep, but for the majority of the day while you're wearing the device, a lot of people report suppression of the tinnitus.
Thank you.
Peggy Ellertson.
Fabulous presentation. I have a cochlear implant, and I also had a revision a year ago, last October. And my surgeon, Dan Lee, who I adore, asked me if I wanted to see pictures of the surgery. And I said, no, just do it. I'm really glad I saw that video. It was fascinating. And it makes me think maybe I'm just going to throw my hat in the ring and go for implant number 2. So I have one question about that. I'm 77 years old. I'm in good health. I know that older people get cochlear implants. My only concern is about the anesthesia. I just, I know that anesthesia for older people is something that needs to be paid attention to. So my question for Dr. Alexiades is, by the way, thank you for all the great work you do in New York City for my friends who now can hear well. My question is, what are the concerns about anesthesia, and what do you know about implantation without anesthesia? I know one person who actually had that experience and it went really well.
Yeah, so anesthesia, and age, like we said, like Paul was saying, not really a contraindication to getting another implant. My oldest patient that I've operated on was 93. So, there's definitely and ecstatic about getting the implant, and it changed her quality of life significantly. So age is not that much of an issue. Yes, there's the concern about anesthesia. In particular, I think it's a conversation to have with your primary care physician as to whether you're able to undergo general anesthesia versus local. We can do it with local, with sedation, and we give you some medications to kind of make you really, really sleepy. It is a little bit more involved, to do that and make sure that you're comfortable, but it is technically doable. But if all things being equal and you're able to actually undergo general anesthesia, the whole surgery itself would flow a little bit faster and smoother because there's less concern of making sure that you're comfortable throughout the whole procedure. But it can be done under local.
I think now that I've seen the video, I would go for the full anesthesia.
Yeah, there's
Thank you.
a couple of parts of the procedure that are a little bit more uncomfortable. And with that, those are the areas that we have to give you some intravenous sedation during those times to make it more comfortable for you.
Okay, thank you.
Wei Ben Wang.
Hello, thank you. Let's see. I was diagnosed a year ago with an acoustic neuroma and have single-sided deafness. So, and I'm currently wearing bicross hearing aids. So I also have some hearing loss in the other ear. I am currently not contemplating surgery. I mean, we're watching and waiting, which I hope can go on for a long time. Is it possible, or is it worth considering a cochlear implant before surgery? What are the implications of that? Anyway, or do I contemplate cochlear implant after surgery?
This is for your other ear?
No, for the one with the neuroma. So I have this ear, the other ear is aidable. The one with the neuroma is not. So it is near deaf. It is, like moderate, like severe hearing loss across the board with like 20% word recognition. So they call it unaidable. So what are my options for the unaidable ear?
So that's not a super easy question to answer, because a lot of it is based upon the status of that tumor, whether it's growing or not growing. Has it been treated, with radiation or not? Because we would not implant your left ear until we knew whether that tumor was stable. So if it's been 10 years with no growth, it's unlikely to grow, and then you could be contemplating just having an implant without needing to have the tumor removed. But if the tumor does need to be removed, you would have to remove the tumor first before you have the implant, because we would have to make sure we can preserve the cochlear nerve. Because oftentimes when we're removing the tumor, sometimes the cochlear nerve gets damaged, and then a cochlear implant's not going to work for you. So
okay, currently it's not growing, but I don't know. I mean, how long a period at what point do you call it stable?
Generally, for the literature, it's 10 years with no growth. However, a lot of it comes into play as to how big it is as well, with respect to how long you would wait. Would you, and again, this is a complicated conversation to have with your surgeon or your doctor who's managing your acoustic neuroma, about whether you get it treated with a gamma knife or cyber knife, some sort of type of radiation, treatment, make sure it's stable, and then and then you go ahead with the implant. So, but if it's been stable just for 2 or 3 years, that's not necessarily a stable tumor. We don't know yet.
Okay, thank you. Thank you.
Leanne DeBerry.
Hi, thank you for the excellent presentation. My question is, well, first, I've been told I should be evaluated for a cochlear implant. I'd probably, be qualified, but because of right now cancer and treatment, that's not feasible. So what I was wondering is these websites that help you with voice recognition, to understand better, would they still be helpful for someone that are wearing bilateral hearing aids? And if so, what are some websites?
Right. Yeah, great. So yes, I work with a lot of individuals that don't have cochlear implants at all. And we work on the things that are mapped out well on these tools. A lot of the tools that I really love are designed by cochlear implant manufacturers, but they have great application, sentence recognition, single word recognition, listening in noise, various different types of speakers. I think if it's helpful, afterwards, maybe I'll provide Tony with some like basic sort of global suggestions. And then if you want more specific ones, maybe we could carve out a time to talk and I could send you specific things, because there's a lot of redundancy too, where some might not really be useful in your case. But a short answer is certainly these tools, people report to me, they have found them to be really useful, even without having a cochlear implant or 2 cochlear implants.
Thank you very much.
Sure.
Svetlana Kuznetsova, excuse me, asked if I would ask her question for her, although my voice is not very good. Excuse me. She's had a cochlear implant for 27 years and just one ear. And she is wondering if she goes bilateral in the future, and at some point replace the older CI, what she should expect. And there's a little more to this question. if the old internal device is replaced with a new one after such a long time, will that damage the cochlea? And are there surgical techniques that have changed, shorter surgeries, no more making a well to which Dr. Alexiades just showed us is still done. And also, are there any new anesthesia techniques? She says she's heard with it about it done with twilight anesthesia. So anyway, that's 3 questions in one, and I think they're all for Dr. Alexiades.
Okay. So let's try to break it up into all the different questions. First, for your original implant that's 27 years old, if it is working well, we don't replace it. We don't upgrade the internal devices. There's not been data that shows upgrading your internal device to a newer generation is going to improve your speech understanding. So we never take out a functioning, working device internally until there is a problem with it. There is always the potential that you don't get a complete insertion of the new electrode into the cochlea due to scarring. So you don't want to take one out that's working properly, for a newer generation one. And because again, we haven't really seen a lot of improvement, generational improvement when you go and upgrade the internal devices. Now, with your other ear, there's a lot of things that go into that, depending on, again, your duration of deafness, whether you've been wearing a hearing aid in that ear over the years, keeping that nerve stimulated. Because all those factors will play into whether a second cochlear implant is going to work for you. If you have not been wearing a hearing aid in that ear, going 27 years and just using your cochlear implant, then the other ear is probably not going to do nearly as well. And so it may not be worth it to think about an implant on that side. But if you've been wearing a hearing aid and you've had some sound awareness and some contribution, then a cochlear implant, could help. Can't tell you whether it's ever going to be as good as your first ear, because it's such a big duration of difference between the 2 implants. And a lot of times people prefer their first ear implanted. The last question you had was about the twilight anesthesia, which we kind of touched on before. Yes, it's doable. So that's definitely an option. With respect to, wells versus no wells, that's a surgeon preference. And like I said, about 50% of surgeons don't do wells anymore, and they just make a smaller incision and just do a, what's called a tight subperiosteal pocket, and others do wells. I am a well driller because I do see patients that their device migrates over time, where the device, which normally starts in the back of the head, starts to creep forward when you don't make a well to secure it. And then it starts to push up against the processor and becomes a little irritating over time. So, I do believe that the device is more well protected when you create a well from trauma. So that's why I like to do it. But again, it's a surgeon preference. So that's a discussion you can have with the surgeon who does your surgery.
Thank you. And thank you, Svetlana, for asking that question. Karen Aronson.
Hi, thanks for the presentations. If I understood correctly, somebody whose hearing is continuing to change is not eligible for a cochlear implant. I've worn 2 hearing aids since 2012, and if I understand correctly, my hearing has continued to deteriorate over that period. So that would suggest that I wouldn't be eligible at that point. Should I expect that at some point it will stabilize, or it'll just get so bad that that'll be it and I would become eligible, or not?
So I'm sorry if I wasn't clear before. You are potentially eligible for a cochlear implant. Having progressive hearing loss is not a contraindication to a cochlear implant. In fact, it's a contraindication specifically for the electroacoustic or hybrid implant for patients who use a hearing aid for low frequencies and a shorter electrode for the mid to highs. So that's a very small subset of patients that you don't want to use those shorter electrodes in those cases, because then as your hearing continues to decline, then you don't get as much benefit as you would if you got a full length electrode that we traditionally implant for patients.
Okay, so I misunderstood. Glad to get the clarification.
Sure.
Thank you.
Deb Marinos.
Thank you. My question is, I'm a person who is losing my vision, and so I'm considered deafblind. I've been told that my left ear over the last couple of years has significantly dropped, and so I should go consider a cochlear implant. And I'm wondering about the rehab process, so the timing issue. You know, I still have a little bit of vision left. It sounds like the rehab process would go easier if I can still read things. And I also heard that my right ear, for whatever reason, is doing reasonably well with speech perception, you know, like 70, 80%. But my left ear is down in, 30, 40%. Do you have any suggestions for how to balance? Oh, I also have tinnitus in this ear, which is quite annoying. The one that's mostly dead.
I can, oh, okay. I can talk a bit about the vision and how that might interfere or play with your rehab. There's many individuals with vision loss that are still able to participate. It doesn't require that there be text in front of you. That's just one way of supporting it. I think of a couple people off the top of my head, maybe with Usher syndrome, who are using like a Braille reader or something like that might be useful, although that might not be your case if you're not quite using Braille, right? But I think a lot of practice at first benefits from having some text sort of support, but it's not completely necessary. We can use objects and I can explain what they are. And with hearing in your other ear, that might make it easier to know the context of what we're talking about. And then I shift practice over to your cochlear implant ear. So one of the things, there's a few different ways of practicing. It's binaurally or bimodally. If you have one implant and one hearing aid, or just two ears in general, I can present you the information such that you hear it with your other ear as well. And then say, okay, now I'm going to present that to only your cochlear implant and see how you're able to do it. So it primes you with what you have without any sort of requirement that your eyes are participating. Truthfully, a lot of my practice, my mouth is entirely covered, so it's presenting sound. The text is often just supplementary at first, but the goal is to be able to do our exercises without any visual, any text support or visual of my mouth. So it sounds like if there's use of your other ear, we can present things and give you the information there, and then connect to your cochlear implant on its own and do exercises that way. Many of the programs that you can do on your phone also have the ability to read the text out loud to you and don't require a visual. I know that's a massive mountain to climb for accessibility, where you get used to your phone being able to read things out loud, but that's also a possibility where it sort of explains where things are on your phone. I hope that answers it. That vision is not necessarily required for practice, but it certainly makes it easier in the earlier stages when things sound a little bit goofy.
There's one question in the chat. Someone was asking about POCD, and I had to ask her what that stood for. Post-operative cognitive decline. And I think this is a question for Dr. Alexiades. I've lost the original question. Do you see that as a result of anesthesia?
So there is the potential of, having some, post-operative cognitive deficits I think they're also asking for some direction towards some resources regarding this. That's not really my area of expertise, and I would probably have to refer you over to a neurologist, to better discuss that. But there's a lot of new data just with respect to cognition and dementia with hearing loss. Like we see the association between hearing loss and dementia. So it is important to try to make sure that you're addressing the hearing loss to try to slow down progression of dementia. They are not causative, so it doesn't mean just because you have hearing loss, you're going to have dementia. But in patients with dementia, we have seen more rapid progression of dementia in patients with hearing loss. And that's because of not being able to participate in conversations, zoning out at family functions, and you're just not getting that mental stimulation because you just can't participate in conversation. So, there is always a trade-off, but I do think that there is more issues for cognition if you are, needing something like a cochlear implant to hear well. I think the benefits of that implant will outweigh, potential risks associated with anesthesia.
Thank you. I want to say that our May meeting, the third Tuesday in May, is on hearing loss and dementia and exactly what that association involves, and what we should panic about and what we should not be concerned about. So it's I forget the date, but it's the third Tuesday in May. Before we leave, I want to call on Tony Iacolucci. She organized this program. Thank you so much, Tony. And she wanted to say one or two things.
Thank you. I wanted to thank Dr. Alexiades and Paul for a really terrific presentation. Full disclosure, Dr. Alexiades was my CI surgeon. And Paul, I wish that I had had your support. And I hope that what people will take away from this presentation is there's a lot of hope out there to have better hearing. I resisted for years, even talking to surgeons, because I thought surgery was a big deal. It was not. I was afraid to lose the tiny bit of sound. I could not recognize words, but I was afraid to lose that. So Dr. Alexiades agreed to implant me in the ear with my acoustic neuroma. And lastly, I was supposed to be a poor candidate because I had not heard a single word, recognizable sound or a word for 15 years. And I literally started to understand words in about 3 minutes through the audiologist mask. And I just listened like crazy to music and podcasts and everything. And music is an absolutely joyous experience for me. So we all have different experiences with our implants, but please don't hesitate to talk to folks and give yourself an opportunity to do this. So thank you, Dr. Alexiades and Paul. This has been really wonderful.
And I'll add my thanks from everybody. And if anyone wants to know more about the meeting or to get any information, write to our info@hearinglossnyc.org address, and I will pass your question on to the appropriate person. So thank you both for a really wonderful presentation and very interesting questions from the audience, and come back in May. So thank you. Bye.
Thank you all. Bye-bye.